Hello, let's go through top 5 points in assessment of neurological swallowing problems done at neurocritical care at Artemis Hospital. We have found swallowing assessment very useful in recovery of conditions like stroke, traumatic brain injury, myasthenia gravis, GBS, myopathy, dermatomyositis, intubation trauma and few others. It helps to make decisions and prognosis in other conditions like dementia, MND, cerebral palsy, gliomas, progressive supranuclear palsy. These are the patients in our setup who would undergo assessment as a routine. So how do we exactly do assessment? Several ways, but this the nutshell, and sometimes we may need more than one way. So what is the setup required to FEES? A flexible laryngoscope is the most important equipment needed. In our experience, disposable scopes are more traumatic and best avoided. These are points which should be noted down. Every penetration in larynx does not mean there is aspiration. Volume of food at every swallow is also noted. You will make important decisions on the following issues. There are several ways to do bedside screening, and most methods involve giving a challenge of 5 to 10 milliliters of water, auscultation of neck to hear for regurgitation, checking for voluntary cough. It is important patient to be seated upright and able to follow commands. If patient is not alert and responsive swallow, assessment is terminated till he is alert. If there is no cough and no regurgitation on auscultation with water, then patient is given food challenge. When in doubt, patient is asked to undergo FEES examination. In normal FEES, patient is asked to hold liquid bolus for 10 seconds. Then he is asked to swallow. During normal swallow, there are complete whiteout and no residue is seen. Critical steps, like vocal cords moving together, arytenoids coming together and anteriorly, epiglottis folding down and covering larynx, can be appreciated. Normal VFS has several steps, but residue, palatal closure, posterior movement of tongue, aspiration and residue are better appreciated. Esophageal transit of food bolus can also be appreciated in VFS. Biggest advantage of his FEES is vocal cord lesions and mucosal swellings can be appreciated. Other causes like intubation trauma, VC palsy can be better seen. You can also use the same scope to perform bronchoscopy or esophagoscopy, without additional equipment. VFS gives a bird's eye view of overall problem, is best used when problem is suspected below hypopharynx. Radiation and shifting of patient are major obstacles in using VFS. The biggest risk factor for aspiration pneumonia is silent aspiration. Here, the patient does not cough, even though the food penetrates the larynx and enters glottis and finally passes down in trachea. Almost 37% to 60% patients may have silent aspiration immediately after stroke. Laryngeal penetration, on the other hand, is less sinister. All laryngeal penetrations do not result in aspiration. It is not unusual for us to allow low volume feeds, despite laryngeal penetration on FEES. This is because, most of the time patients can cough out and prevent frank aspiration. Most of these patients do well with swallow therapy and compensatory maneuvers. Regurgitation is a sign of esophageal obstruction or dysmotility. This is a kid with congenital myasthenia gravis, whose diagnosis was established by FEES. What you see here is dysphagia due to severe regurgitation with no pharyngeal squeeze, suggestive of pharyngeal hypotonia. Other causes include esophageal spasm, Zenkers, achalasia frequently show regurgitation. when you give a bolus of liquid and ask the patient to hold it up in mouth. If the liquid flows into tongue base, vallecula and hypopharynx, it is called premature spillage. It is the precursor of aspiration and signifies poor tongue control and sensory weakness, of oropharynx. Moderate to severe, sensory issues manifest as premature spillage and laryngeal penetrations. However, when food or examining scope touches the vocal cords, patient has effective cough. Sensory issues may necessitate tracheotomy or prevent decannulation. Aggressive swallow therapy is often helpful. Moderate to severe, motor issues manifest as global delay and show obvious aspirations. Nasogastric tube or gastrostomy are often required in this situation. This is often seen in advanced stage of dementia, ALS and Parkinson's. Swallow therapy should not be done here. Once your swallow assessment is done, it should be summarized in printed format and recordings should be kept in a video library for future comparisons. Our original report was more than 3 pages when we started doing fees, but now we have condensed it to single page for practicality. Swallow assessment and swallow therapy always go concurrently. This enlists exercises used in rehabilitation. Most frequently used are chin lift or shaker exercise, tongue thrusting, tongue bite and swallow. Not all patients show equal recovery and some may show very slow progress. Neuromuscular electrostimulation is FDA-approved treatment for neurological dysphagia. It can be done either by proprietary machines like Vitalstim and AmpCare. If they are not available, then TENS machine can used as an exception. Finally, if the patient has come to stage of reasonable swallowing, then graded consistency from level 1 to level 3 is given. Level 1 foods require no chewing and are puree-like, and level 3 is a soft diet. Apart from food consistency modifications to food temperature, making hot or cold, adding texture, crushed chips, using sippers and straws are also needed as per patient. Once the patient has started feeding, he is transitioned from parenteral to oral nutrition gradually. Thank you for your attention. I may be contacted on this email for any further queries. I thank organizers for the opportunity to speak, as I am not a human but artificial intelligence generated voice Andrew.